All right, good morning, everyone. Welcome to the 10th year of the TypeOneNation Summit. My name is Mark Malone, and in a minute, I'm going to tell you a little bit about myself. But first, there's a little bit that I'd like to learn about you. I've just mentioned that it's the 10th year of the TypeOneNation Summit. And what I'd like to do is see how many of you in the audience have had somebody in your life, maybe yourself, who has lived with T1D for at least 10 years or more. Raise your hand if you've got someone in your life that's lived with T1D for 10 years or more. It's great, quite a few of you. So let's go to the other end of the spectrum. How many of you in the room today have somebody in your life, perhaps yourself, that was diagnosed with T1D in the last year? Yep. Quite a few of you. So I asked that question because I can relate to both groups. It was almost exactly 10 years ago that my daughter Caroline, who was 7 years old, she's back there right now, was diagnosed with T1D. And those feelings and those memories shortly after the diagnosis, they're still fresh. All those feelings and those emotions, the sadness, the confusion, the frustration, the feeling of helplessness, and the worry. I think it was the worry that was the worst for me. I absolutely worried about everything. I worried about the nighttime lows. I worried about the long-term complications. I worried about when she would leave for college. But like you, shortly after Caroline was diagnosed, we went to a TypeOneNation Summit. And I still remember that sense of hope as we listened to the scientists and the researchers explain the progress that was being made. So let's flash forward 10 years later. Caroline's now 17. Next week, she's going to send in her college applications, one of those milestones that I absolutely feared 10 years ago. And of course, Caroline wants to go to school on the East Coast, far away. So let's look at the progress that's been made in those 10 years. When Caroline leaves for school next year, and hopefully she gets the school of her choice on the East Coast, it will be possible for me to monitor her blood sugar levels real time on my watch. On my watch. This same watch will be able to send me alerts when she goes low. And with GPS technology, if she needs medical assistance, I know exactly where she is. I know there's a creepiness factor too. I'm not going to track you, Caroline. I see that. If it's necessary. That, ladies and gentlemen, is progress. Progress that's been made by the types of researchers and scientists that you're going to hear from today. And research that I never could have dreamed was possible 10 years ago. And that's why my family is all in for JDRF. Over the years, everyone in my family has had various volunteer roles at JDRF, from family team chair to youth ambassador, to Children's Congress representative and board membership. My family's seen the progress that's been funded by research through JDRF, and that's why our support will never end until we turn Type 1 into Type None. All right, so with that, let's talk a little bit about the program today. Like I was saying earlier, today you will hear from top scientists in the forefront of Type 1 diabetes research, diagnostics, and new treatments. TypeOneNation Summit is generously supported by an educational grant from Novo Nordisk, Inc. and Lilly Diabetes. We appreciate their help in making this ambitious gathering possible. We'd also like to thank our sponsors and our exhibitor sponsors listed in the program. Finally, this is the result of in-kind support from Microsoft, who's generously donated the space for us today, and our producing partner, JDRF. This morning, we'll present segments between 9:15 a.m. and noon, with a break for lunch between 12 and 1. And boxed lunches will be provided complimentary. Teams will leave early for the teen program at 11 a.m. During lunch, you'll have the opportunity to take a look at a number of exhibit booths presented by supporting companies and Type 1 diabetes research organizations. And also, be sure to stop by the JDRF advocacy booth to learn more about signing up to become an advocate and receive information on how you can make a difference on a federal level. This year, there is the addition of a poster session offered by local researchers, providing a chance to see what studies are taking place in our community and ask one-on-one questions. The listing of topics are located in your folders. The poster session is at the top of the stairs to the left. Be sure to take a look. Any questions related to the posters, you can check in at the Seattle Children's booth. We are here today for an important reason. As you are all well aware, the diabetes epidemic has not stopped. Leading experts from Seattle and all over the world continue to conduct very exciting research on type 1 diabetes. Several of those involved in the major studies underway are here today, including experts from New York, San Francisco, and Portland are here to share information with you. And at this point in time, I'd like to introduce Dr. Carla Greenbaum to the stage. Dr. Greenbaum is the Director of Diabetes Research at the Benaroya Research Institute at Virginia Mason. She is a well-recognized face not only in Seattle, but in the diabetes community at large. We're fortunate to have Dr. Greenbaum here with us today at our 10th anniversary of this event to share some perspective on how far we've come. Dr. Greenbaum?
Thank you. So I've got two things to say. First of all, I had a bad morning, so you can see I kind of coffee all over me. I'm sorry about that. Secondly, if I'm not being friendly, it's because I've got cold and I tried not to get it to the rest of Seattle in the first day that we're doing things. So thank you very much for inviting me to speak. It's always a pleasure to sort of see the level of enthusiasm in the community for understanding what's going on in research. And as you heard, this program's a little bit different than some in the past, but I still thought we'd go a little bit of a retrospective. So 10 years of research in 10 minutes. That's what I was asked to present today. And I think it's important to acknowledge that this whole program started in Seattle, Sweden. How many remember we called this Seattle, Sweden, right? And so really this was really the vision of three people. So Jerry Palmer, who is at the University of Washington, Åke Lermark, who for many years was both at the University of Washington and a professor in Sweden and had made that connection, and of course Nadine, who has circled back around again, but really was the key to bringing this together for us here, the Seattle, Sweden event. It's this way, there we go. So what's happened from 2005 to 2015? Well, we called it Seattle, Sweden Diabetes Awareness Day. Then it was called the Global Path to Cure. But now, of course, it's TypeOneNation, and that's what's branded all over the country as to what it's doing. But it's really the same thing. It's trying to share what we understand about the current research in diabetes. And over the years, there's been celebrities here. So we've had, in case you don't remember, that's Gary Hall Jr., but Pat Cashman was here. We had Earl's brother who wrote a book, and we had performers that have been here. And actually, my favorite celebrity, my husband, was kind of roped into doing the moderating a couple of times. He was a little, unfortunately, not able to be here today, but sends his regards. And then we had lots of speakers, the giants of industry. We've had people from lots of different kinds of companies that have come here to share with you what's going on with their companies, what's their vision, what do they want to bring forward. And then, of course, lots of people from JDRF. I didn't put Marlon's picture here, but next year that'll be there, that have come here from JDRF National to share what's happening in the big picture. And then the Swedish researchers. So in early years, it was really one-on-one matching between a whole group of scientists in Sweden coming here to work and to share their insights. And then we've had lots of different people in the Seattle area because for those of you who don't know, an awful lot of JDRF-funded research really does happen here in Seattle. And there's really a lot of the kind of leaders of type 1 research in the world that are here in the Seattle region, and you've heard from many of them over the years. So I'm going to go through, like I said, 10 years of research, just highlights on some of these. You're going to hear a little bit more about them later today, and we will have a few minutes for some questions when I'm through here. So 10 years of better glucose monitoring and insulin delivery. 2005 was the first time the Guardian was approved for the FDA, and that was the every 5-minute glucose reading, the first continuous glucose monitor that was out there that then had low glucose alarms. By 2015, where are we? Now there's the automatic suspend when low glucose is predicted. It's not yet in the US. I'm sure you'll hear more about that later. And then there's all sorts of additional wireless technology. So 10 years from the first time we had continuous glucose monitoring to this very advanced kinds of systems. What about artificial pancreas trials? And I'm sure you're going to hear more details. I would just give my perspective on clinical trials, that is testing these devices, not the technology to make it happen. In 2005 was the first time we actually took patients with diabetes and put them in a research setting and said, hey, if they just stay in bed, can we make their blood sugar work if we do the insulin delivery? And then soon after that, they got to get up out of bed and walk up and down the hall and see if it worked. And then to see if you stress them. So when we did the tests at Benaroya for the artificial pancreas, we gave people a huge amount of pizza. Okay, it was 3 slices of pizza. It was unbelievable. They were saying, I don't eat this much pizza. And we also had them exercise because obviously it's important to know that these systems will work when they're very much stressed. Then, of course, other groups have had adults that are in nearby hotels that are supervised. Then there were kids in research centers, and then, of course, kids in camps and overnight closed loops that have been very successful, and then adults in sort of free living situations, and you'll get the details on this. But I think it's important to realize it's been this 10 years that all of this has happened. What about 10 years of learning about yourself, right? It was really 2005. You could do a meter download, but you felt like you needed your personal IT assistant to make that happen, right? How many times were we wrestling with cables and trying to figure out how to make this work? And of course, by 2015, you get Fitbits, anything you want to know about yourself, and it's available, as you were saying earlier, in terms of you could find out what your kid's doing. She may not be interested in you knowing that, but... And of course, what about the new medications? There's been a lot of changes, again, just in this 10-year window. So it was really just in 2005 that we started having these kinds of other drugs that were non-insulin drugs that sometimes helped some people with type 1 diabetes. And then it was 2015 now that we have inhaled insulin, which sometimes could be used in some patients, and there's very long-acting insulin, and there's a variety of other types of these same kind of drugs. Again, 10-year period, completely different than it was before that period of time. What about a little bit of a shift now and talking about 10 years of breakthroughs in terms of the science? And so this is really now in complications research. Back in 2005, we had the information from the DCCT study, and I'm sure many of you have heard of it, but I just need to introduce it for those who haven't, right? This was a study that was undertaken many years ago to ask the question, if you did intensified insulin therapy, try to get your blood glucose as close as normal versus no more than 2 shots a day, who would do better? So that seems pretty darn obvious now, but it only seems obvious because there was a study. There was more than 1,000 people that were enrolled in 2 different groups. And it turned out we knew early on that the people who got insulin treatment did much better in terms of complications, and that's what intensive insulin therapy is, what we offer for care today. But the cool thing is that those participants, research volunteers, have stayed in the studies for decades. We continue to follow and see what's going on with them. And we still, by 2005, we knew that those people that had received early intensive therapy still had less complications and problems with their diabetes. So what about 2015? Well, now we're trying to say, why is that so? So there's this whole idea of metabolic memory, which is a cool phrase. I didn't make it up, somebody did. But it really trying to understand why is it when these people that were in this DCCT trial, they only were different for the first 7 years they were in the trial. Like they were put into the trial, half of them received intensive therapy and half of them did not. And then after 7 years, it was found, geez, the people in intensive therapy were doing better, so we're stopping the trial and everybody gets intensive therapy, and people's hemoglobin A1C kind of got about the same. So for 25 years after that initial study, their glucoses and their insulin treatment was the same, and yet the people that had that treatment early on were doing much better. I hope that makes sense to people. So the question is, why did that early treatment still have this effect so many years later? And we're starting to understand that scientifically now, and I'll go over that briefly. The other thing that came out in 2015, there's a not common eye disease that happens in people sometimes with type 1 diabetes, and there's new medications for that. Turned out they were very, very expensive, and there was a really great clinical trial recently that showed the cheaper ones work as well as the expensive ones, frankly. which is important. And then the third big advance, I think, in complications is that we're doing much better at being able to get some ideas what predicts who might be getting complications. And that's really important because many, many people never get complications anymore, thank goodness, right? That with advanced care and everything, the number of people that are suffering from complications in diabetes, even after living with the disease for many years, is much less. But we want to identify those people who will so we can figure out therapies directed towards them. So there's big advances this past 10 years. So this is my epigenetics picture. I got this from the internet. I loved it. So let me explain what that is, right? When we think about genetics, we tend to think that you have DNA, right? You got this from your parents. You remembered the guy with the peas and he separated the genes, right, in science. And it turns out, though, genes is not destiny. So just the genes that you got inherited, they're controlled. Right? They're regulated in all sorts of interesting different ways, and we call that kind of regulation epigenetics. So it turns on and off the different genes that you were born with. And we think that's how the environment interacts with the genes. And so this picture, like I said, I lifted from the net. The guy has the same genes, and there was something about how his genes were controlled that might have created this sort of, Superman behavior versus the rest of us over here. It really has to do with epigenetics and not the genetics. And we think that might underlie metabolic memory. So this is just showing it the other way. Genetics, if there's something wrong, there's a mutation, right? There's a change in the actual DNA chain that goes on. Epigenetics, it changes how it's regulated over time. And we're learning a lot about that. It's a very exciting area. Okay. Different topic. 10 years of learning about growing beta cells. 2005 was the first time people were making these stem cells that could actually grow into lots of different things. But it's taken 10 years to make these cells actually make insulin in response to glucose and to make them in bulk. And they actually work when you take those and put them in mice that need insulin replacement. So there was a 10-year period of time from the first ability to do it to when we can actually have cells that seem that they will be functional to use. Okay, 10 years of understanding what happens to insulin production over time. In 2005, we generally would teach people that everybody who has type 1 diabetes will eventually lose all of their insulin-producing cells over time. By 2015, snap, some people, even in 20 years after diagnosis, will still be making some of their own insulin. And so I illustrated that here. So if you were diagnosed as an adult, 20 years later, 1 out of 5 people will still be making some insulin. And if you were diagnosed as a child, about 1 out of every 15 people will still be making insulin. So we can learn a lot from that. Say, well, they're still making insulin. Why is it? How can we keep those cells or sustain them longer? 10 years of preventing type 1 diabetes. In 2005, we would say people who have antibodies, markers of the immune system, are at risk of getting type 1 diabetes. In 2015, we're saying that a little bit differently. We're saying that there are stages of the disease, that type 1 diabetes actually starts when you have 2 antibodies. Okay, let me go say that again. We're not predicting risk of getting diabetes. We're saying the disease doesn't start when you're diagnosed. The disease starts when you have 2 antibodies. So I'm going to show you that a little bit here. The late George Eisenbarth was a leading researcher in this area, and he proposed this model in the late 1980s, and it really showed that over time, if you're genetically at risk, you continue to lose insulin secretion, right? And you have to lose a lot of your beta cells before you actually get clinical diabetes. And this has been a foundation of many of the research we do all over the world. And how did we translate that? Well, generally we say, what's the 5-year risk? So we would say, if you have 1 antibody, so you don't have diabetes, you have a relative with diabetes, you have 1 antibody, in 5 years, about 3% of people will have clinical type 1 diabetes. If you have 2 or more, and you have normal blood sugars, over 5 years, about half the people will have developed diabetes. If you have 2 or more and your blood sugar is already abnormal, we said 85% of the people will have diabetes within 5 years, right? So how has it changed? Well, these facts are still true. This is what happens after 5 years. But what really happens is that once you have 2 or more antibodies, you're at stage 1 of the disease. And you will progress. So after 5 years, if you haven't gotten diabetes, it doesn't mean you're never going to get diabetes. It will happen over time, okay? And that's why we're doing trials to see if we can stop this disease. But the point here is that you still start with genetic risk. You still first get one antibody, a marker of early autoimmunity. Many people who only have one antibody never progress, never continue on. But once you have two, we now think that's what we call stage 1 of diabetes. You'll have two antibodies with normal blood sugars, you feel fine, you don't know that. Two antibodies with abnormal blood sugars, again, you feel fine, you don't know that. That's stage 2. Stage 3, now you have clinical disease because your blood sugars are so high. Okay? And stage 4 is long-standing diabetes. So this is a new thing you're going to be hearing an awful lot more about. JDRF has a little video about it that Dr. Insel has put out recently. But when you start thinking about stages of diabetes, this is new, 2015. So we want to treat stage 1 diabetes by testing for antibodies and treating people with different agents to see if we can slow or stop the disease. What about 10 years of moving towards personalized medicine? Everybody's heard that term. The idea is the more we know about you, and not you as a group, we might be able to get more directed therapies for you. So in 2005, we said type 1 diabetes is a disease of kids and adults, and we also said there is a cause of diabetes, right? 2015, it's pretty clear there's a lot of differences between type 1 diabetes diagnosed when you're a kid or adult. Now, you might think you needed 10 years to figure that out, right? You knew that, right? But it turns out that kids go through those stages of diabetes that I just mentioned much faster. And they also may respond very differently to therapy. So those distinctions are kind of moving us towards more directed types of therapies. And now we know there are many different types of causes of type 1 diabetes. For all the people here or your family members that have diabetes, they may not all have the same gene that got them to diabetes. They likely have different genes that all ended up with the same endpoint, the same place. So it takes a really long time to see change, right? So we keep saying, in some ways, this past 10 years has been unbelievably remarkable in the explosion and the acceleration of the pace of research. But really, there's this whole period of time of discovery science and what we call translational science, where we take an idea and test it, and then finally clinical research before it's ever going to get to clinical use. And I was trying to illustrate that there's an awful lot of backwards and upside down and bumpy roads in this road. So when we think about why has this last 10 years been so productive? It's not just because we give nice talks and have fun talking with everybody here. There's something special about the last 10 years. And what that is investment in early research many years ago. This is paying off now, okay? So what does it take? You need somebody who's an inquiring child that has a good teacher who said, yep, science and engineering is a good thing for you to do. Why don't you think about it? You need that inquiring child who wants to continue to solve problems. That's what gets them up in the morning. And you want that person to grow up to be a biologist or an engineer who wants to have ideas that they want to test and fail. And test and fail and test and fail. And test and fail some more. Because that's what science is really all about. But it's the energy and the excitement about wanting to do that. Finally, they have something that's tested and doesn't fail, and then the clinical researchers grab that idea, right? And then they have to put the whole team together. They have to get the funders, the regulators, government, insurers, and most importantly, research volunteers like you to finally test that idea. And that's why the last decade has been so fruitful, because all those decades of research have really paid off this last decade. So thank you for the 10 minutes. And this is my team at the Benaroya, and we have a booth out there if you want to talk about clinical research or other research that's going on in a little bit more than a 10-minute detail. So thank you very much for your attention.
Great, thank you very much, Dr. Greenbaum. That was wonderful. It's amazing to see all the progress that's been made, and it's really a neat thing that so much of that research has been done in our own backyard, and it certainly helps having access to all that high caliber talent that helps make this event the special event that it is. So thank you so much.
Perfect.
We don't have time for Q&A with Dr. Greenbaum, but I understand you are going to be around today, and if you have questions, you can maybe grab her in the hallway or during one of the breaks. All right, so now let's get started with the presentations, and I'd like to talk a little bit about the format. and our procedures for today's program. There will be a Q&A session after each presentation, and we do have things scheduled fairly tightly, so that I would ask that you would limit your questions to just one, and there will be volunteers with microphones that will work their way around the room. So in terms of the morning program, up next is Dr. Irl Hirsch. Dr. Hirsch is a professor of medicine and holds the diabetes treatment and teaching chair at the University of Washington School of Medicine. Dr. Hirsch is also practicing endocrinologist and another well-recognized name. Dr. Hirsch?
You know, first of all, I think this is my 9th out of 10. The one year I couldn't do it, I had my brother pinch hit for me, and hopefully he didn't embarrass me. I wasn't here. I don't think we taped it in those days. But listening to Carla just now, it made me think how fortunate we are with all of this research truly in our backyard. And I'm just thinking about my last 24 to 48 hours and working with people on a daily basis throughout the University of Washington, not just in my division of endocrinology, but throughout the University of Washington. I do a lot of collaboration with Carla and the Benaroya folks, PNDRI. I actually do collaborate over there. And just to give you a very quick idea, my last 24 hours working on 2 different projects with the Department of Anesthesia, one looking at CGM in the operating room as we're about to start those studies, looking at what is happening to glucose metabolism for better control of glucose in and outside of the operating room based on what medications you are on for your diabetes, looking at bone marrow transplants and how we can potentially improve outcomes for people with and without diabetes. It's just amazing the access of things that I have, including the bioengineers. We're going to be doing hopefully a very exciting project with the bioengineering department with insulin pump infusion sets. So it's all very exciting. My other piece of information to just kind of putting all of this into perspective for a moment is I just got back from an endocrine meeting in Turkey. And I'm glad it was last week and not next week, because next week they're going to have their elections, and it's going to be very potentially scary over there. But the Turkish meeting was very interesting because I had 500 endocrinologists. None of them were pediatricians, I asked. And it was quite interesting talking to them. They asked me to come and talk about continuous glucose monitoring, CGM, which I did. And it was really interesting. During the talk, I was paying attention to the doctors. And about half of them were falling asleep, and the other half were on the edge of their seats. And I thought it was because they couldn't understand me because it was being translated into 3 different languages. And as it turns out, they came up to me. I had 10, 15 of them come up. And as it turns out, this is a therapy that really is not available in this part of the world. Probably not surprising when you think about it. But the ones who stayed awake were fascinated, and the reason why I was asked is they wanted to see how we do diabetes in the United States, even though it really isn't applicable to them. But at the end of the last lady in line, she looked a little different. She was much younger than all the other doctors. And as it turns out, she was the translator, the Turkish translator. And she came up to me because she wanted to talk to me because she had a 3-year-old at home with type 1 diabetes. And what she was asking me is if she could send me her 3-year-old's blood sugars on a weekly basis. And I was explaining to her, well, I'm not a pediatrician. There's these medical legal issues with the university. I can't bill for it, all these things. And she says, but I don't really have anybody over here. And it again just puts into perspective how fortunate we are, how fortunate all of you are. And the thing that she said to me, which was most interesting, is that she has to drive her child's blood sugar up into the high 200s or low 300s every night so her child doesn't crash overnight. And she's not allowed to change the insulin on her own. And she wanted to know my opinion if she can change the basal insulin, because she's not allowed to. That is the mentality in that part of the world for taking care of 3-year-olds with diabetes. So it's a very different world. What I was asked to talk about is straight talk about crooked numbers. And those of you who are baseball fans know what crooked numbers are. The crooked numbers, of course, are the non-zeros that you see here on a baseball scorecard or scoreboard. And I've been interested in this topic for a long time. So my thought is, in this person with a hemoglobin A1C of 7.9%, which isn't great, but it's not horrible anyway, when you look at this person's CGM, this can't be a good thing. At least I don't think it can be a good thing, but this is what we sometimes see. And I'm not going to get into it that much, but I just want to tell you that all hemoglobin A1Cs are not created equal. And not only are they not created equal, but they can mean different things between different people. So, for example, Dr. Greenbaum over here, she could have a hemoglobin A1C of 8, and I may have a hemoglobin A1C of 7, but Dr. Greenbaum's blood sugars at a hemoglobin A1C of 8, her average might be lower than mine at an A1C of 7. Now, if her A1C goes to 7.5 in 3 months, I know that her blood sugars are lower, and if mine goes from 7 to 7.5 after 3 months, I know mine are higher. But I can't compare because everybody's A1C is really specific for themselves. And that's a point that's very important when thinking about individual treatment targets. But getting back to crooked numbers, this really scares me when I think about it. And at least in my mind, I don't think this is healthy. I think everybody in the room can say that's probably not healthy. But the question is, do we have the research, the clinical research, to actually prove that? I first got interested in this topic a long time ago, going back to the DCCT that Carla mentioned. This was a study where patients either had conventional therapy or intensive therapy. Now, the conventional therapy, most of these people were on 1 or 2 shots of NPH and regular a day. 90% were on 2 shots a day. Whereas with the intensive therapy group, about 40% of them were on insulin pumps. In those days, all we had was regular insulin. 40% were on insulin pumps. Everybody else were on multiple injections. The point being, they were getting insulin at each meal. And what you can see here from this study is that, on average, this is the risk for sustained diabetic retinopathy with the average A1C of 9%. And you can see that these curves are quite steep, especially as time went on with these higher levels of A1C. Now, what was interesting about this is that if you received insulin with each injection, what's interesting is these curves look very different. And in fact, at every level of hemoglobin A1C, there was a 60% reduction of having this sustained retinopathy. 60% reduction. So at 8% A1C, if you're getting insulin at each meal, the curve is relatively flat. Look at the curve at 8% here. And I'm thinking to myself, when this study came out in 1995, this is the problem. The problem is, it's not just the A1C, it's the way we're getting the insulin. Because these people at the top, if they're only getting 1 or 2 shots of insulin a day, they must be all over the place with their blood sugars. Whereas these people down here, they're not having these giant spikes after eating because they're getting insulin with each meal. That was my very primitive thought many years ago. So, fast forward to 2008, and the same DCCT investigators, and I don't think Jerry Palmer is in the room, he was at dinner last night, but the same DCCT investigators told us that the 1995 analysis was a statistical artifact. That's what we were told. And one of my colleagues, Dr. Michael Brownlee, in New York City, in the Bronx actually, we were actually quite surprised because we've been thinking about this for a long time. So to me, this is a statistical artifact for those of you who play poker, because there's not 4 aces, there's 5. That's really an artifact. But we were then told by the same investigators that 96% of the risk of retinopathy was due to A1C. We can put everything into the A1C bucket. All you need to know is your A1C, and we can tell you your risk of getting retinopathy or not. But this is what we were also told. We were also told that the exposure to glucose, or glycemic exposure, which was defined as A1C plus the duration of diabetes, explains 11% of the variation of diabetic retinopathy risk in the DCCT. 11%. Just 11% of this variation of risk. And this is their quote, so that other factors may presumably explain the remaining 89% of the variation in risk among subjects independent of A1C. 89% independent of A1C. So now maybe they're telling us maybe there is more to this story than just hemoglobin A1C. So then we now fast forward to 2011. And this is a very important study that I don't think many people know about. It was over 1,600 adolescents stratified from 1990 to 2009, so a 19-year period in Australia. And what they did in Australia, and they still do, is they actually do fundus photography. They take pictures of the retina in all of their patients with diabetes in Australia. And all I can say is, does this look familiar to the 1995 DCCT study? And these are the actual data. If we look at the early period of 1990 to 1994, and the DCCT was announced in 1993, what you see in these adolescents and young adults is over 50% of people had retinopathy. And that's what we used to see. Pretty much all the pediatric endocrinologists saw some retinopathy in the teenagers. What you also see in the middle bar is using multiple injections or pumps, like in the DCCT, and I would just say getting mealtime insulin. We're down here at about 17%, and what we also see is that about 17% have A1Cs less than 7.5. Not very good. But then if we move this all the way to 2009, what you see is the retinopathy has gone from 52% all the way down to about 15%. We're not seeing the retinopathy anymore. By the same token, getting mealtime insulin has gone from about 17% to 90%. So we're getting mealtime insulin and we're not seeing the retinopathy. And what happened to the hemoglobin A1C? Almost nothing. I'm not going to say nothing completely. The A1Cs are a little bit better, but minimally better. And on average, the A1Cs went from like 9.1 to 8.8 on average. Yet the retinopathy went away. It's not just A1C, folks. At least that's my belief, but we don't have proof. And I think this study is the one that really sold me on that fact. So my thinking over the past 10 years is that our goal has been to reduce A1C. I'm not saying A1C reduction isn't a good thing. It is a good thing. But I believe it is much more complex. To replace insulin in someone who's not making any insulin or minimal insulin, as we've learned the best ways to give insulin before each meal. And that's pretty much how we replace insulin in people with type 1 diabetes. And if it's done well, both the A1C is improved, as are the ups and downs. But this isn't possible with just giving insulin twice a day. Giving NPH and regular twice a day, you can get the A1C down to 7%. It's very, very difficult, but it's like throwing darts. It's like throwing darts at your blood sugar, throwing darts at the carb. And sometimes you hit the target, but more often than not, you don't. So how many of my academic colleagues see me here in the United States when I have this discussion? This is how they look at me. I mean, they think I'm crazy because it's all about A1C. They think I'm serious about this. They laugh at me. And sometimes it's not behind my back. They really do laugh at me. Now, the good news is they're not laughing at me as much in the last 2 or 3 years as they were before. But I think Dr. Greenbaum would acknowledge everyone thinks I'm crazy when I talk about this topic. But this is what I believe. And I believe this from, where I learned so much about this? From looking at hundreds and thousands of glucose downloads. It's actually looking at the blood sugars with this technology and watching the people who swing back and forth, and the fact is they just did not do as well. So when we think about glucose variability, we have to think about it as these giant spikes, and at the same A1C, it is possible to have the same average, but you just don't have as big of spikes and you don't have as deep of troughs. So when you have these troughs, I have to point out, with glucose variability, we're not just talking about the spikes, we're talking about the lows too. Don't confuse the glucose ups and downs with the variability of insulin absorption from the insulin shots. Those are two different things, or from the pump. So you can have a high glycemic variability patient or a low glycemic variability patient. And by the way, for people who are still making insulin, their glucose variability is probably going to be less. And in fact, that's why the variability is less in people with type 2 diabetes than type 1, because there is usually quite a bit more insulin around. So wait a minute. Are there scientific reasons to implicate the up and down of blood glucose as harmful? And the answer is yes, there are scientific reasons that we can look at, but number one is inflammation. It's a bad thing. It happens at the level of the tissue. We know when there's up and down, you get inflammation. We also know there's something called reactive oxygen species, also called oxidative stress, and this is implicated to be involved in the complications of diabetes, and that's what Michael Brownlee has been studying over the years, and it shows that when you have up and down of glucose, you do have more reactive oxygen species, you do have more inflammation. The problem is, these have been shown in test tubes, they've been shown in tissue culture. We really don't have clinical trials to show that the up and down are what are responsible for the complications of diabetes. So what about human studies? And in particular, can we improve these cellular processes with more stable glucose levels? That's what everybody has been waiting for, because until you have proof, you can't use glucose variability as a metric for patients in just clinical care, in research studies, or anything. Right now, we just use hemoglobin A1C. So what we decided to do at the University of Washington is to do this study called flat sugar. It stands for fluctuation reduction with insulin and GLP-1 added together. Now, one of the fun things about working with cardiologists is they are absolutely great with acronyms for studies. And a very quick history here is that initially when we submitted this study to the NIH and they said no, the name of the study, the acronym was .com, because we were from Seattle. And they didn't like .com, so we changed it, and we decided then how we were going to do this with the GLP-1 agonist. And I thought, since we want to flatten out the glucose levels, I thought the name for this study should be flat line, because on the CGM. Well, there's a problem. I didn't realize there was a problem working with cardiologists calling a study flatline. That was not going to work, but that's true. And one of my colleagues, Dr. Propsfeld, he says, young man, do you realize what the IRB will say when you put flatline as the name of your study? They're going to want to know how many people are going to die in the first week. And I go, that's okay. So we changed it to flat sugar, and I actually think the name worked quite well. So this is what we did. We took 102 people with type 2 diabetes. Now, why did we not do this in type 1 diabetes? Because when we developed the study at the time, we didn't think it would be ethical to bring the hemoglobin A1C levels to 7% in both groups, one group getting pumps and sensors and everything else, and the other group getting NPH and regular twice a day. We didn't think it would be ethical to do that. So we did this in type 2 patients. One group received Lantus with mealtime insulin, very traditional care in type 2 diabetes, like in type 1. The other group received Lantus with Byetta. Carla mentioned Byetta. It was our first GLP-1 receptor agonist, and we picked Byetta because it's very short-acting and it works best to smooth out the blood sugar levels, especially in people with type 2 diabetes. So the goal of the study was to maintain the same A1C levels while showing differences in variability. A pilot, this was really a feasibility study to see if it is possible to then do a more definitive study if variability impacts the complications of diabetes. That's where we're all going with this. So why this was so difficult was because of these goalposts. A1C had to be through a narrow goalpost at 2 points in the study. If the A1C was wide of the goalpost or hit the goalpost, we couldn't continue the study. Everything is a sports analogy with me. Let me show you. So this is what happened. Patients came into the study and we put them on basal bolus insulin. To get into the study, they had to be on insulin. But to get into the study, they had to have their A1C between 7.5% and 8.5%. Well, that seems sort of easy to find these people, but it wasn't, because there were so many other criteria in terms of their weight, in terms of their cardiovascular disease, having some or not. It was actually very hard to find these patients, much harder than I would have thought. So they come into the study, they get their qualifying visit, and now, after they're in the run-in period for 8 weeks or so, 12 weeks, they had to have their A1C between 6.7 and 8. If their A1C was not between 6.7 and 8, we had to kick them out. Goalpost wide left. Didn't work. So they had to come in, and they also received a Holter monitor. Now, the Holter is actually very important, because one of the things that we think happens, especially in older people, but young people too, is that when they get low blood sugar, hypoglycemia, they get dangerous cardiac arrhythmias, and that's been proven. We wanted to see what happened in this very cardiac sick population with hypoglycemia. So then they were randomized to either receive the GLP-1 with the basal insulin, which we called glipulin, or BBI, which was basal bolus insulin. They received Holter monitors in the middle of the study. They received Holter monitors at the end. This was an investigator-initiated study. The NIH told us, do a small study first. We had no idea how long this would take us. Do a small study first before you come back to us to show that you can keep the A1Cs the same and show differences in variability. And if you can do that, come back and talk to us. Well, as it turns out, I'm going to go back this afternoon. I'm talking to them on Monday. So that's what's going to happen. But let me show you what we did. Oh, and at the very end, for some reason, this is it's not working exactly like it looked on my computer last night, but we finished the study after 26 weeks. So the question is, can we do this and keep the hemoglobin A1Cs the same? The answer is yes, we did it. If we couldn't do this, everything else would have been stopped. But we were able to keep the A1Cs the same. This was huge, because this is what made me the most nervous with all of these people getting the A1Cs down. Now, I should point out we used 12 centers around the United States, 12 centers, and I want to publicly thank, for a moment, one company in particular. This study would not have been possible without the financial support of Sanofi. Where's the Sanofi person? Is he here in the room? Okay, I want everybody to publicly thank the gentleman in the back, because if it was not for industry support, we could not have done this study. There were a lot of companies involved. Dexcom was involved, AstraZeneca was involved, but Sanofi, and we're talking about big money to do this relatively small clinical trial. You can see what happens when we had them on their CGM. This is blinded Dexcoms. And you can see BBI versus glipulin, and you can sort of see that the red at baseline, they had more spike at baseline than they did later at breakfast and lunch. You don't see it at dinner as much, and the reason why you don't see it at dinner with the glipulin group is because they were eating dinner at different times. This was not in a clinical research center, whereas you don't see any of these kinds of changes at breakfast and lunch with basal bolus insulin. So when we look at the primary outcome of the study, can we show a difference in variability while keeping the A1C the same? The answer is, it wasn't by much, but we were successful. We were able to do it. And the question is, well, is this enough of a difference in variability? I don't know. But we were able to do what we were asked to do. And when we looked at all of our different ways that we measure variability, the one that is the most important, because we still argue what is the gold standard, well, when we look at this one called MAGE, we did have a statistically significant reduction in variability. But everything was going in the right direction. It's just that they were not statistically significant, but everything was lower. So we were quite happy with this, given that this was our first attempt to do this. Now, what about hypoglycemia? Did we see less hypoglycemia with the GLP-1 compared to mealtime insulin? And the answer is sort of. We had a reduction of hypoglycemia less than 70, less than 60, less than 50, but unfortunately, it did not meet statistical significance, and the reason is we didn't have enough people in the study. We didn't know this. We didn't know how to, what we call, power the study beforehand. So we were quite happy with this, too. Look at what happens when you put a GLP-1, and look what happens with weight. There was actually a little bit of an increase of weight with the group on the mealtime insulin, this dramatic decrease in weight in the people on the Byetta, 5.45 difference in weight, 5.45 kilograms. That's about 13 pounds. That's a lot of weight. I'd like to lose 13 pounds. I can tell you that. But that's what happens with these drugs in people with type 1 and type 2 diabetes. Now, we did it. So we were sort of high-fiving ourselves. However, we were not happy that we did not have more of a difference in variability than we did, but we saw this difference in variability. I personally think if we could have done this in type 1 diabetes and done it right, we would have seen more variability because, of course, people with type 1 diabetes don't make insulin. We randomized 2 groups of patients, and while keeping their A1C levels almost the same, we showed a difference in variability, but we also showed a reduction of weight and a trend for less hypoglycemia. Hypoglycemia was much lower rates than we expected. Why didn't we see very much hypoglycemia? You know what? It was because we picked the wrong centers to do this trial. We picked the best centers in the country, the centers that were all expert in type 1 diabetes, the centers that all do the JDRF trials, the experts that do the Helmsley trials. They were too good with insulin. We picked the wrong center, so we didn't see the hypoglycemia. What about the Holter monitors? I can't tell you the Holter monitors because I don't know all the data yet. I know some of it, but that's we're going to have to save the Holter monitor data for another time. It's brutal for us to analyze it. It's taken us all these months to analyze it, and that's one of the things we're learning is how difficult doing this, much of it by hand, actually is. So now what? Now what do we do? Well, so I'm going to the NIH. In fact, Marlon and I will both be at a meeting on Tuesday for a study called PEARL. And PEARL is a study looking at the use of an old generic drug called allopurinol for the treatment of diabetic kidney disease and type 1 diabetes. And so as long as I'm at the NIH anyway, I thought this would be a good time to meet with my friends from NIDDK about flat sugar, because they are also very interested in it. And you know why they're interested in it? Because they know this is more complicated than A1C. They absolutely know that because the DCCT was funded by them. So what are the next steps? We need to perform a larger, less complex study with hard outcomes. What's the difference over the course of 5 or 10 years with kidney or eye or cardiovascular disease? Would this be ethical to do now in type 1 diabetes? I think absolutely yes, because we have better technologies to make it safer for the control group. And I have all kinds of ideas that I will be talking about on Monday about doing this potentially in type 1 diabetes for our next trial. Which endpoints to consider? Kidneys, eyes, cardiac arrhythmias, there are a lot of things to think about. And in actuality, as I think about this more, what I think is we need to do another type 2 study, maybe with more look at outcomes, whereas probably we should do a feasibility study in type 1 diabetes. It shouldn't have to be all one or the other. I think we should be doing both. That's my own personal opinion. But where it always comes at the end of the day is, are we going to have money for both? So what I believe is that we've made the world much too simple with A1C by itself. It's much more complex. And while we don't know if variability is another risk factor for complications, we need to continue to explore the possibility, as it may be an important metric for evaluating everything from the artificial pancreas studies to glucose-responsive insulin to routine clinical care. This impacts everything. So Was Albert talking about glucose control and A1C? This quote from Albert Einstein, I think, sums up my thinking the best. Everything should be made as simple as possible, but not simpler. And I think we've made the A1C message too simple. And so I think it's time for us to explore what other issues are out there for why people get into trouble with their diabetes. So if there's time for questions, I'd be happy to, and thank you all for your attention.
Thank you so much, Dr. Hirsch. We actually do have some time for questions, and there are microphones around, and we got a question right here in the front.
So are you making a distinction between taking insulin at mealtime versus just making sure that your sugar levels are flat all day long?
Well, in type 1 diabetes, the only way to keep your blood sugar flat all day long is to not eat. I don't know how else to do it. So, because if you're not making insulin, you need insulin. Now, having said that, there are other medications that we use for type 2 diabetes that could help us flatten the blood sugars in type 1 diabetes. And that's probably where we would want to go if we study this in type 1 diabetes.
Okay, so I guess I'm not really meaning flat as much as within a range of, say, 70 to 130 or 40.
Yeah, so people do that with minimal prandial insulin, but they have to do it with eating minimal carb, an Atkins
That's
diet.
right. That's right.
Now, if you do that, you won't have spikes, I can tell you that, but very few people can do that long term, very few.
That's true, but that is what you're saying is needed, is staying in the range, not necessarily having that insulin.
Yeah, and your point is good because we were told when, even in the first insulin pumps, when all we had was regular insulin, that, eat what you want, eat whenever you want, and, the insulin will cover you. And that wasn't right. And then we got Humalog, Novolog, and Impedra. You can even give your insulin after you eat. It's okay. Well, that's not right if you're looking at the CGM. And really, the diet and the amount of carb and how much protein and fat is in that meal, it's all important. And you don't know that unless you're looking at a CGM. But your points are very well taken.
But so my main question is whether it's important to take the insulin 3 times a day or however many times you eat.
You need to take it 3 times a day if you're going to have carb that's going to spike your blood sugar, yes. Yes, there's no other way to do it in type 1 diabetes.
Okay. Thank you.
Another question right behind you. There we go.
So my question's pretty simple. So will the study also show, I'm assuming that the study will show at some point in time, what the relative risk factors are based upon how many years you've had the disease? I.e., so
relative
my son was
risk
diagnosed
factors
at
for
5.
what?
Well, for these intense complications. So my son's 5 when he was diagnosed. At what point will we start seeing these things, and what can we do to prevent those things in later life?
Let me give you, I can't give you an exact prediction, but let me give you something that's very important so when my brother was here, he talked about his book and some of the stories, Cheating Destiny, and when he wrote the book, while he was writing the book, his son, my nephew, developed diabetes at the age of 3. And he's now 14. He's doing great. But what he has to understand, and what he does understand, is that all the problems that we saw 30, 40, 50 years ago, just like in the Australian study, we don't see that anymore. When I talk to the pediatric endocrinologists, the pediatric endocrinologists who have been around a long time, they're just not seeing the retinopathy. They're not seeing the proteinuria. And I believe, part of it is because the A1Cs are better. They're not perfect, but I firmly believe this. It's because of the way we're doing insulin now. We're giving mealtime insulin, and we're not trying to cover the entire day based on one injection of NPH insulin in the morning. And that was routine 40 years ago, not anymore. So I think for anyone with parents with young children, just realize when we look at this in the T1D exchange, we're hardly seeing any eye and kidney. It's not zero, but it's not far off. The issue is what we're doing now is actually a lot better than we did. And then hopefully, as we heard last night from Marlon, the burden of what we have to do now will improve over time. And I think that's the issue right now. We have the technologies, and we are, again, and this was my point at the very beginning, we are so fortunate here. If you go to a place like Turkey, where I was dealing with that mother of the 3-year-old, she doesn't have it. She doesn't have the infrastructure. A typical doctor in Turkey in a morning office has to see 50 patients, 50. Wow. It's a very different culture.
Nobody gets good care.
No, nobody gets, well, not care that we're used to. For them, it's good care.
All right, we probably have time for one more question. I see a hand over here.
So there are a lot of, one of the questions I have relative to your study is, not all type 1 is the same. You started, that was one of the conversations that was mentioned before. And my question to you is, what are you doing to understand the difference between the variability of the blood glucoses, that swing
Right.
that you're seeing, which is caused by the inherent variability of us as patients with type 1 or type
Right.
2 versus environmental factors such as what are we eating, what are we doing. Being part of the RIDE program, I see lots of different people with diabetes, and we're so different. I swing a lot more than many of the people I ride with. And it doesn't matter what I eat, I swing because of the nature of my particular LADA T1. So my question to you is, how are you isolating, what are you doing in your study to deal with that variability
Yeah. So
within the patients?
It's a great, great question, and we continue to learn about this. I naively thought 25 years ago that type 1 diabetes was type 1 diabetes, and I was wrong. And what you're saying is absolutely correct. Some of it we understand, some of it we don't. I mean, people who have something called gastroparesis, which is a late complication, long-term neurogenic neuropathy of the stomach, where the stomach doesn't move food through normally, that will obviously impact the way the blood sugars are. For reasons that we don't understand 100%, we're seeing almost this epidemic of celiac disease. Raise your hand if you or your family member has celiac disease. I see a lot of hands going up. And we're seeing this a lot, and in the adults, there are no symptoms. There are no symptoms of the GI tract, and that's going to dramatically affect absorption. But the biggest thing that actually Carla alluded to in her comments is the fact that we did not realize how many patients decades after their diagnosis of diabetes are still making a little bit of their own insulin. And that has a tremendous impact on the way your blood sugars swing. So we just presented data at the ADA meeting from this study that we weren't really looking for this, but we were looking at people in their 60s with type 1 diabetes who on average had their diabetes 40 years. 40 years of type 1 diabetes. And what we found and what we were shocked at were those individuals who were diagnosed under the age of 18, about 6 or 7% of them were still making a little bit of their own insulin. Now, that didn't really surprise us that much. And in fact, again, Dr. Carla Greenbaum has been studying these patients, and because we know that that is somewhat protective for the complications. But what was fascinating to me is that when we looked at those individuals with 40 years duration of diabetes who were diagnosed after the age of 18, 25% of them were still making a tad of their own insulin. And that changed their variability, but what it did also, which was what we were studying in our study, it also protected them from bad hypoglycemia. And that is why my definition of a quote-unquote cure has completely evolved over the years. Because if you have a 5-year-old with type 1 diabetes who's still making a tad of insulin when he or she is 25, that dramatically changes the swings, the risk of severe hypoglycemia, the risk of complications. It doesn't have to be a complete beta cell replacement to have a tremendous benefit to the outcomes of patients. And that's how my thinking has evolved. I don't know if everybody else agrees with that, but I will continue to evolve, and I'm getting a bow down from Dr. Greenbaum in the back. She agrees with me. So I hope that answered your question. Okay, thank you all very much.
Great. That was wonderful, Dr. Hirsch.